Oh, I just covered it. All right, hello everybody and welcome to the PT on Ice Daily Show. My name is Christina Previtt. I am one of the team within Modern Management of the Older Adult. Our crew has 3 courses in our geriatric curriculum. We have our 8-week online Essential Foundations course, and the next Essential Foundations is starting the first week of January. And then if you've taken that course, we have our 8-week online advanced concepts where we take all the things we talk about within that course and really try and deep dive into different clinical populations. That course starts January 13th. And then we are all over the United States for our live course in 2023. So best way to probably know where we are is if you sign up for our MMOA Digest. We have an email that goes out every second Friday, including this week. So we kind of talk about where we are by region in that email. So you can go to ptonice.com/resources and be able to sign up there. Okay, it's getting towards the end of the year, and I was thinking about a different recap episodes that we could do or things that we could talk about. And one of the things that kind of jumped front of mind was to do a little bit of a reflection or reminder for a lot of us about communication tips when we're working with older adults. You know, we hear all of those really awful stories where individuals go into surgery and they have no idea what's actually happened to them. They have no expectations or have not had any expectations set around, you know, how long their recovery is going to be. I had a patient once who was talking to the resident about to go under for a rotator cuff repair. And he said, you know, it's going to take 6 to 12 months to recover. And that was the first time he was hearing that. He thought that he was going to have his sling for 6 weeks and then he was going to be good to go. So he literally walked off the surgical table because he said, I am not at a level right now where it is bad enough that I need to spend 6 to 12 months rehabbing this, which is super interesting. And then he ended up on my caseload and we rehabbed and strengthened up his shoulders. But that's just one extreme example where we can have these types of communication breakdowns in healthcare. And this is not just physician medicine, this is in allied health as well. And it happens across the lifespan. But when we're working with older adults, they've had a lot of time for some of those interactions to accumulate. And so when you are seeing them and they've had, 30, 40, 50 plus healthcare interactions, not a ton of them have been overly positive. A lot of them are talking about things that are really negative. It can be really tough because you're getting a full blast of their angst when it comes to interactions or dealing with the healthcare system. And you're coming in hopefully as this fitness forward provider who may be speaking also a very different message than other people have spoken to them in the past. So I have 9 tips that we're going to talk about. I hope that all of these are reminders. And if they aren't, I hope that you can start implementing these in your practice today if you're on your way to work. So number 1 is be at the person's level. If you are working with someone who is bedbound or wheelchair bound, there is nothing that can be more intimidating than having a person standing over you. It really does can really zero in on that power differential that can sometimes be very evident in healthcare and something that we're really trying to avoid. We really want to try and promote collaborative practice with our patients. And so the first thing that we want to talk about is just being at that person's level. Bring up a chair if you're in a hospital, kneel down if they're in a wheelchair, and just be able to speak to them face to face. Because looking up at whether we recognize it or not, that body language of that difference in height can really make a big difference from the perspective of a person's role within their healthcare interaction, making it seem like this person that is coming in as the clinician is the one who's in that seat of power and the one that should be making all the decisions without any input from the person. So number 1 is be at that person's level. Number 2 is use patient first language. this is probably my biggest pet peeve, but also probably the thing that I see most consistently happen within allied health in general, where you talk about a person as a total knee, or as a stroke, or as whatever their health condition will be. And for some people, for example, some people in the autism community, they like having that as an identifier. But for many things related to musculoskeletal pain or chronic disease progressions, or the diagnosis of chronic disease, we don't want that disease state or that musculoskeletal pain complaint to be an identifier to that person's identity. And one way that we can promote that from not happening is making sure that our language reflects that as well. So instead of saying, I'm seeing 2 total knees and a total hip today, you're seeing 2 individuals with a total knee replacement and 1 with a total knee or a total hip. And some people say, well, Christina, I never say that in front of my patient. Again, this is something that can subconsciously come into our thought process, whether we recognize it or not, that we're dissociating the person's condition from the person. Where, we really want to be promoting whole person practice and holistic care, and we advocate that in all of our tenets within ICE. And so starting by, modeling that using patient first language really just helps to reinforce that. And the language that we are using in our own thought speak and our own interactions with our colleagues will definitely percolate into our interactions with our patients and the way that we are communicating with them. So that's number 2. Number 3, with our older adults, don't assume that they can't hear you. And it's hard because if we get into a lot of interactions where we are having individuals who are hard of hearing, we can assume that they can't hear you. And so we can naturally go into a much higher range with our volume. And our older adults, 1, may not have any hearing impairment, or 2, may have a very good hearing aid that is enabling them to hear at that level. And so it can be a sign of ageism where we assume that a person can't hear us. And so the way to move around that is to ask, am I speaking at a volume that makes it easy for you to understand me? And then they can give you that feedback, oh, actually I am really hard of hearing, or I have a hard time hearing on my right side. Can you stand to my left side? And then we can make sure that they are hearing us, that we are at the appropriate volume to have a positive interaction, and that we are making sure that we are not just assuming that because a person is 80 years old that they are going to be hard of hearing. So something to be mindful of. Number 4, we want our older adults to be allowed to make informed choices. Our aging process can sometimes feel like a gradual loss of independence, or the capacity for people around us to allow us to assume risk. And the best example of this is what we see in the falls prevention space. We use these scary statistics that there was even one that was going around social media that if a woman falls, that she's 50% more likely to die in the next 12 months or something. And it wasn't even true. But the second thing was that those very scary statistics make it so that family members or healthcare providers can be saying, well, Mom, I don't think you should be doing that anymore. And they can feel pressured or unintentionally bullied into stopping doing things that they would like to assume the amount of risk that it entails in order for them to continue completing a task. And so we want to say, if there are certain activities that people are doing, say, this is what some of these risks are. These are ways that we can mitigate some of these risks. And then you make the choice. If, your fear of falling is greater than your want or desire to continue completing this, then the decision is that you no longer complete those things. But if you are having this conversation with me and you decide that you're going to keep that mobility aid, even if I recommend a different one, our older adults are adults. I make decisions about risk every single day and nobody questions that from me. But we get to a certain age and individuals think that they know better and that they cannot make those choices for themselves. So we want to make sure that we're in that collaborative space where we kind of commit our argument or let them know our argument, and then they can make that choice. And it may not be the choice that we would make, and that is okay. Number 5, and this kind of comes into the same thing, is that we want to take the time to explain what is going on. And that can be as simple as asking, like, do you know what this surgery entails? Do you know what the recovery is going to be like? I loved getting individuals who were trying to get as strong and resilient as possible for a total hip, total knee, any type of surgery, because I was that person who had the time to sit with them and say, do you know what's going to happen? Have they explained that to you? Do you have any questions? Do you have any questions about what's going to happen after? You know, in pelvic health, we do this all the time with birth prep. In the older adult space, the setting of expectations and knowing what they are going to experience and what is normal, what happened, all of that is so powerful, because we can prevent sensitization if we know that individuals are informed about the things that they are going to be experiencing, or what is within the realm of aging physiology and what is something that is a musculoskeletal pain complaint or a pathophysiological change that we are going to want to address. So that is number 5, take the time to explain. The amount of times I have individuals who have had surgery, who have no idea what happened to them, had no idea what their expectations for recovery were, is really upsetting, and something that we need to be working on as a healthcare team. Number 6 is we need to be okay with individuals not wanting to participate. And that's not saying that we come in for therapy and people don't want to, and we're like, all right, see you later. You know, we want to try and discuss like the needs. Sometimes we want to be that cheerleader, but you're going to get individuals who have absolutely no desire to increase their physical function. And this one for me is probably the hardest, because I see the capacity for everybody to be able to improve. But we have to acknowledge that sometimes our clients aren't going to want to, or they have no need to, or that they are at a level where their expectations of where they should be at this age match their current capacity levels and are okay with letting go of other aspects of their physical function. And that is okay. So we want to allow them to not want to participate, and we want to be that cheerleader. We want to try and say, you know, you will feel better if you move a little bit. That fatigue that you're experiencing will improve if we continue exercising. How about we just do a couple of movements? You know, we're going to have those conversations, but we're not going to really coerce individuals into trying to go into therapy, because it just doesn't make for a really great experience. Number 7 is we don't want to just talk to the family. I think as allied health, we're really good about this, but just something as a communication tip to make sure that is on my list. We want to make sure that we're talking to the individual. The family is going to be asking questions, but we want to make sure that our evidence-informed care, our clinical practice is around the person that we're treating, and being mindful of caregivers and supports, etc. But making sure that we are being respectful of the fact that we don't want to be talking around a person about their own health. We want to allow them to be a very integral part of that conversation, because it's important, and we want them to understand what's happening too. The 8th one of 9 is to recap what you went through or what they've told you. It's both. Let me make sure that I have heard you correctly. Is this what you're feeling? Is this what's aggravating and easing? This is kind of where your irritability is. Is that correct? Or let me just kind of go through the big things. Like, I've done a lot of talking today. Here's the 2 or 3 things that we are going to have as like our big takeaways. And that recap, that summary, is really important. And then asking, do you have any questions about that? If you have any questions, please do not hesitate. I am here to help you. I am here to facilitate this, and let me know, and we can have more conversations about this. That's number 8. And number 9 is asking individuals what they think is happening, or what they think they need. You know, what do you think is happening? And you're going to have individuals who are going to say, well, I'm not the doctor, you're the doctor. And, you know, my response to that is always, yes, but I have met you for the last 30 minutes, hopefully. You've lived in your body for, 89 years. You know your body better than I do, even with my knowledge in physical therapy. And I'm here to guide you, but I'm here to guide you within your lived experience, not my assumption of how you live your day to day. And so getting an idea of what they think is going on, what they think will work for them, can be a really great way to kickstart that therapeutic alliance and get individuals believing that they are being heard. And that's what we want, is individuals to feel heard. All right, I threw a lot of things at you, so I'm gonna practice what I preach and talk this recap through. So 9 communication tips for working in geriatric practice. 1, be at a person's level. Number 2, use patient-first language. Number 3, don't assume that they can't hear you. Ask about volume, and if the volume that you are speaking at is allowing them to understand you clearly. 4, allow them to make informed choices, and that includes being able to accept a certain amount of risk, even if that is not the choice that you would make. Number 5, take the time to explain and set expectations of what is going to happen, whether that's in rehab, in surgery, in a course of care, whatever that may be. Take that time to explain. It'll make them feel a lot more supported and part of their healthcare experience. Number 6, allow them to not want to participate. Allow them to accept where they're currently at. We're going to try and have our argument around why therapy is important, but some of our individuals are not going to want to do that. This is definitely the hardest one for me. Number 7 is don't just talk to the family. Make sure that our clients can sometimes be very passive about their experiences because healthcare interactions have often been around them, not directed towards them. And so we want to make sure that our clients are active participants in their healthcare conversations. Number 8 is we want to recap what our clients have said to us, recap what we have gone through so that we have these takeaways that they feel like that we've heard them and that we have actionable steps for them going forward within rehab. And then number 9 is ask, what do you think is going to work? Or what do you think is going on? Because they live in their bodies 24/7. We are coming in as a impartial observer of their movement patterns. And so they are going to be able to give us a lot of insight into what they think is happening. And it gives us a starting point to build therapeutic alliance, but also to start our intervention. All right, that's all I got for you today. I went a little bit long. If you are interested in seeing us on the road, MMOA Live is hitting the ground running in 2023. We have a ton of courses coming. Sign up for MMOA Digest to see if we're in your area. So if you want to go to ptonice.com/resources, we have a ton of those for you, including signing up for MMOA Digest. I don't think I'm on here before the end of the year, so have a wonderful Merry Christmas and Happy Holidays and Happy New Year. And I'm going to see, I'll be here for pelvic, but not for Geri. But I'm still going to say enjoy the rest of 2022, and let's start 2023 off with a bang. Have a great day, everyone. Bye.